or almost afternoon. My name is Charlotte Parent, and I am standing in for Dr. Karen DeSalvo, who is the Health Commissioner for the City of New Orleans. I am her Deputy Director, and she's sorry that she could not be here with you all, but as a government official, when the City Council calls, you go. City Council wanted to talk about mental health and behavioral health this morning, so they brought all of the players for that within the city to get a report on what's going on. And so that's where she is. And up until about 10 minutes ago, she was still trying to get here and had me on standby, and then finally decided, this is not going to work. I need you to go. So I am here to sort of tell the story about where the New Orleans Health Department currently is, and a little bit about our past and how we got to where we are, and talk about the state of health in the city of New Orleans. After Katrina, the City of New Orleans Health Department came back, was one of the first things to come back. And in our past is that we provided a lot of direct services to the community, meaning we ran clinics, provided more pediatric clinics than anything, keeping kids well, doing immunizations and that sort of thing. Some adult clinic work, WIC clinics, which are big. A lot of safety net services for the city, which is a role, that public health does play. And we did that and wasn't doing it very well, meaning that after the storm, there was a series of community care clinics that were developed within the city and through what's called the Greater New Orleans, Primary Care Access Grant, which was money given to us by the federal government to stand up clinics within the city after Katrina at the neighborhood levels. And so the clinics were to run with, of course, quality systems in place, providing primary care, case management, those pieces and parts that could make it a full service facility for the citizens. And so the City of New Orleans clinics, which did run under the PCHG grant, had very little money to get that done, and this group of clinics took off and were doing very well. So when Dr. DeSalvo and I moved over into City Hall and began the administration running the health department, we made a conscious decision at that point that we wanted to make sure that our partners in the community that were doing the jobs well, we gave those jobs to them if we had them, that we would release some of the burdens of what we were trying to do under the health department so that we could focus better on real community public health and things that would make a difference to the whole community and not just the safety net services, because we had providers out there to do that. So we struck out on an ambitious plan at that point. We decided that we would transition all of our clients from our pediatric services and adult services into those community health centers, and we gave ourselves a timetable that went from October of 2010 to the following April. We were going to be out of providing those services. And we called a lot of our colleagues across the country, and everyone said, yeah, right. Do you realize how long it takes to do that? And you need this and you need that. And we said, well, we're gonna try to make this work because we do have this network out here that can absorb these patients and absorb them well. Our intent was never to turn things over and not make sure that those clients were taken care of the way they needed to be taken care of. So we embarked on that plan to close our clinics in terms of doing this sort of care, and we worked hand in hand with the state Medicaid office to make sure that we could make those transitions. We then followed up when we made those transitions with the state Medicaid office to make sure that the clients did make those connections and walk the clients through that. And at the end of April, 2 of our clinics were transitioned out to the primary care clinics, and we had a rate of 98% of our clients were seeing other doctors in those other clinics. The third clinic was in New Orleans East, and as you all know, that's been a place where we've really tried to get our hands around what healthcare should look like for that area and how do we get it out there. So it took took just a little longer, but we finished in August of that same year making that transport. So we created our first mission was to go ahead and get those services from under the health department so we could take the little funds that the health department gets, okay? Health department for us, we only have a budget of $1.8 million to do all the services in the city that we provide. The majority of our money comes from grant funds and other avenues that we are all the time seeking out, trying to figure out how to provide these services. So we took that, made that transfer, and then decided to use the road under public health accreditation to be our map going forward. And how are we going to figure out how public health looked in the city of New Orleans? So while we were running on this road, we continued doing other work. The community was ripe at that time to make real changes in terms of what public health should look like. Big focus for us initially, lots of people wanted to focus on childhood obesity and nutrition. And so we went ahead and said, okay, what can we do as the health department to help kind of capture all that energy around that? And we brought together people who were interested. We thought we would have about 30 people at the table. We had 150 people at the table from the community who wanted to do work around childhood obesity and nutrition. This was the beginning of what's called FitNOLA. And some of you may be familiar with that, but that is the city and the community's plan on how we're going to defeat childhood obesity and become the fittest city by 2018, which is the city's 300th anniversary. So FitNOLA was a plan that was developed in conjunction with the community. It is not a health department plan. We don't own it. We don't want to own it. Our job is just to make sure that the community is working together to help that happen. So we convene to make that go. We look for grant funds to make it work. So that was the first leg of our work, was to create something for childhood obesity and nutrition. The second spoke in our wheel that we started working on was access to care. And so you have in New Orleans, at that point, all of the healthcare systems were kind of just discombobbled. What do we do? Who's what, where? You had neighborhoods like New Orleans East at that point that really had nothing. You had other neighborhoods where people were building and you had plenty of things coming, so it's like, how do we make sure that healthcare is spread to everyone and not everyone building in one place? So we really embarked on trying to find out who was going to be doing what, where are they doing that, created another document that laid out how does access look for us. And so when people come to us and they're looking to put healthcare in different places, we can then inform them by data, where's the best place? Where do we need it? What makes sense for the city to move on? So that access plan was created, and that group now is working on what, for us, if the Affordable Care Act and the changes are not adopted by our state, where do we go within the city? Because we have a large amount of people who are not covered, and we have an opportunity here to make sure that they are. So what does the city want to do in terms of looking at that, and how do we make sure that we get some access to some of these fundings that are going to come down to make sure people are covered? So that's what that group is now starting to work on, and how do we make that look, and pulling the people together to talk about that. The next big thing under the spoke of the health department is violence and behavioral health. Okay. Violence for the city of New Orleans, as everyone knows, it is our biggest public health problem. And the city has a plan called NOLA for Life, which is the entire city's plan, but the health department plays a major role in that plan in looking at preventative services. What can we do to make sure that while they're working to stop the murders on the other end, we're trying to figure out how do we start from young to make the changes, the paradigm shifts that have to happen, that we don't have the violence that we have. The city of New Orleans has stood high in terms of murders for 30 years. This is not a problem that's a new problem. It's been here for a long time. People have looked at it. People have thrown different things at it to try to figure out. But the main thing we want to do now from the health department's perspective is look at prevention. And so with the programs that we do still have under the health department, everyone has a theme underneath it that's about violence. And if it's our children and families projects, what are we doing in terms of domestic violence, right? How do we reach those women that we're still seeing in our WIC clinics and help to screen for domestic violence so that we can hopefully point in the right directions. Also, programs where we're teaching parenting, right? What do we start young teaching to help parents cope better and understand how can they work with their children so you don't have those issues that come later that lead to that. One of the primary focuses for us right now is breastfeeding. And breastfeeding, while it's a nutrition issue, right, it's really a bonding issue. And children who don't bond from young, we know have problems further down the line. So we've started in our programs to see how we can make the difference at the younger ages. We're also working with the schools to do trauma resiliency. And if a school has a murder, our role in that is to be able to bring resources, if that school needs it, to deal with the trauma when it happens for those kids who have been affected by it. So we have a trauma team that will go out. First, we call the schools to see if they need that, if the school has it, and they have people in place. Then our role is just to say, great, glad you got it. If you need us, call us. But if they don't, the team will then sort of get to the school and figure out what they need to do for the kids that's in it. That piece for us is our way, again, we don't run the schools. The city really has not even a say in what goes on with the schools, but we've offered that technical assistance and that work so that we can start delving into the problem of violence. The behavioral health piece was another mapping exercise in terms of what's out there. What do we have in terms of behavioral health? Who can we help? What are the pieces and parts that are there, and where are the gaps? So again, that was another piece to just create some documents that tells you what do we have for children, what do we have for adults, what do we have for this. All those documents are on our website, and you can pull them up, and they are updated constantly in terms of if things have changed or what's out there. It's available for the public. It's not, again, for just anything that the health department uses. We want the public to know what it is, what's out there, and making sure that's available. There's a separate guide for children and youth. We did one that includes everything, and then a separate one for children and youth, so that information could be put out there. So there's a lot of work going on in the behavioral health realm. As I said, she's over there talking about it right now, and what's the access. And, you know, a lot of it is about how we're working within the city, but of course we have to work with the state and different people as to how we make sure those things are happening. So we have put ourselves, again, in that position to be able to start the conversations within the city about what do we do, and making sure that if the programs are there, how do we link them all together, and they're not working in silos to make that happen. The next piece of what we have focused on is the health department in general. The health department is a very small place. We're located on the 8th floor of City Hall. We have 18 employees in the health department. We have many more who are hired by the grants. And when I say 18, I'm talking about who are funded by City of New Orleans tax dollars. There's 78 in total who are working on different grant programs and in there. We've been very lucky. We've had lots of interns who've come in and worked with us, taken on big projects and done remarkable work to make that happen. Also have had fellows from the CDC and that sort of thing. And they play a major role in how we have moved some of these projects forward. When we took on looking through accreditation as to how we wanted to look in the future, the accreditation roadmap basically just points to you what are the things that you want to do to make sure that you have a true functioning public health department. If you're working in a hospital, it's a lot like Joint Commission, except that with Joint Commission, you know, you're really getting into heavy rules and regulations regarding patient care. A lot of what we're doing is how do you put out public health? How do you reach the community? What are the standards that are there? Are you following HIPAA standards? And there's like 12, 13 measures that we have to do. We decided, and if you all don't know Dr. DeSalvo, she is like, let's go. When she first got here, we were laughing about this yesterday, she said that we would be accredited by December of 2011. Okay, we had just got there, and it's like, oh, yeah, right? Can we do it? It's really, though, we had made our goal would be that we would get our application in by January of this year, and we have. And we're expecting our site visit sometime in the summer, fall. So our goal was to be accredited by now the end of 2013. And if everything goes well, we will have at least hit our site visit and moved on to accreditation. And what that does for us is it validates the fact that the changes that we made to change us into a true public health authority and the work that needs to happen are validated on a national level, that you are doing the things that need to happen, and you have a department that can stand up with any of the other departments in the country. We recently received an award from Robert Witch Johnson as what they call a Roadmap to Health City. And this was an inaugural award, and we were one of 6 cities chosen out of 150 to be at the top of our game in terms of where we go with public health. So for us, that was a good validation that we're doing the right things for the community, that we're meeting and listening to the community as to what needs to happen. So that just pushes us a little more to keep going where we're going because it's working. The final thing on our big picture agenda right now for New Orleans in particular is emergency preparedness. This, of course, is another public health issue for us. In New Orleans, when we think of emergency preparedness, we're thinking about evacuations for hurricanes and that, all those things that happen. But emergency preparedness is a lot more than that, and there's a lot more for the city of New Orleans. We had this week a water notice, and after Katrina with the sewage and water board, the pipes, the old pipes in the city, we're going to have more and more of these as they work towards repairing what needs to be repaired. But this is a public health issue. When we had the marsh fires out in New Orleans East, that is a public health issue. And the health department has to respond in kind to, what do we do? What do the citizens do if this happens? And respond in a way that gives the facts of what needs to happen, keeping calm, in terms of what to do and how to do it. But all of these are considered, public health concerns for the department. But primarily, our piece that we focus on is for the hurricane season. In particular for the health department is the fact that we have a large population who need assistance in terms of evacuation and have medical special needs. Now, medical special need may mean that they are not ambulatory and can't evacuate on their own. It may mean that they have medical equipment that if the electricity goes out, right, it no longer operates. Very big, and a lot of what we saw during Isaac, when the electricity went out, we had many people who were on oxygen at home. And you sort of know that, but it really came to light in Isaac when the electricity stood out for a number of days, and we started getting calls from people who were home and no longer had oxygen or no longer could use the electric oxygen containers. And so it was, okay, what do we do? They obviously need oxygen. How do we get them where they need, or how do we get that to them? So Isaac really pointed out to us that either we had the issue with the equipment, we had issues with where they live. There are quite a number of what's called assisted living facilities in the city of New Orleans. Most of them are high rises, right? So imagine if the electricity is out, which it was, and you have persons who cannot ambulate in a wheelchair and they're on the 8th floor of a building, and they need food, right? Because if they're up there and food is run out for 3 days or 4 days, potentially that's there. Or you have to figure out how to get them down, right? From the 8 floors down to the 1st floor. So a few things that we did is, one, the immediate concern is coming up with those plans to make sure that we know where those people are. So we spend a lot of time all year long going out to these facilities and identifying those people and registering them with us so that we know what's there. And so that if we know we need to make it out there to get those persons, we know where they are, where they live. We know that we need the fire department to come with us. We need EMS. We need this sort of thing to get it coordinated. But in a bigger picture, what we started doing is we're working with the federal government to help us identify well ahead using Medicare data. And this is a lot of health information exchange and stuff that we can then know who in their database has that medical equipment, right? So if we know that at this particular high rise that houses 350 people, 200 have medical equipment that's electrically dependent, and we need to know about them, we know that that's one of the first places we need to get to. Okay, we have another building that maybe only has a couple of people that needs it. Maybe we take those persons, move them to that other building so we can sort of do what we need to do to take care of as many people as we can in one place. It's going to do a lot to help us identify and make our work a lot easier to understand what we need to do in an emergency. We have limited resources in terms of people. We have limited resources in terms of being able to fund just going out and doing this work. So a lot of it is preparedness on the citizen side to help us identify. But even with that, and that was how we approached our program before, that people identify to us that they have a need, and we've tied to Entergy to help identify who they are. People still didn't identify. And if the emergency happened, we're still the ones that need to help. So we're trying to figure out ways that we can be proactive in this and get that information ahead of time and encourage people to register. That would be the first thing we want to do. But if they haven't, then at least we know what's on the ground within the city so we can start working towards making that an easier transition. The other thing we found out is citizens really don't want to evacuate, right? If they don't have to leave their home, they don't want to leave their home. So what can we do that and do we always need to evacuate? And that's what we're finding out now. After Katrina, of course, the word was we always leave, right? Well, we're quite a few years out now. Things have gotten better in terms of the levy system for us within the city. And so to shelter in place makes a whole lot more sense. It's very hard to move those numbers of people to somewhere else, right? Instead of trying to figure out how to leave people stay at home and what can you do to help if that's the case. So we're even exploring if people shelter in place, what can we do as the health department to either get information out to them, get oxygen, whatever it is, to them versus taking them from somewhere to deal with that one problem that they might have. So there's a lot of work and innovation going on as to how do we deal with an emergency and that it's not an emergency, that you're not dealing with it just when it happens, but it becomes part of your norm. It's a year-round effort in terms of trying to make it work and coordination within the city and with the citizens on what needs to be done. That'll always be a part of public health now. I think that after Sandy, people sort of forgot about what happened here and almost at times couldn't understand, the urgency and preparedness and what we were doing for these type of events. And I think after Sandy, it was like, oh yeah, that really does, happen. And it's not just in that area, it's in another area that people then saw that we're all vulnerable in some way, shape, and form, and that the plans need to be there to make sure that they're not, that people are ready for that to happen. So we focus and will focus a lot on public education to make sure that people know what needs to happen, whether it's for an emergency or any of the other things that we're doing. We are focused on putting the community together and linking people with like ideas and like needs and ideas that they want to work on together so that we can potentiate what everyone is doing rather than everyone sort of doing their own thing and it not serving the greater good for the city. And we want to convene. That's what we feel right now our role is. Our role is to make sure that the needs and the priorities of the citizens of New Orleans are met to the best of our ability and putting the people together out there who's working on these needs and priorities so that they can talk. People don't always do that. They don't use data to help drive what's there. And we're becoming a more data-driven program. Health in general and persons, we're all very emotional and sympathetic to what's going on, and we want to think we know what the problem is, but without the data to really validate that is the problem or where we need to go, it really is just like throwing stuff at a wall and seeing what sticks. So we're moving to where we want to use the data. We're looking for different data sources to do that. The health department itself has not historically been data rich, but we are learning how to get that data and how to use other partners to help us put that data together. And the federal government has been a very strong partner for us in terms of helping us. When you've come with a good idea on how we can use that to move forward, they've been very open to figure out how can that happen for you all, because they can learn from us to take it other places and make it work. So we've been very lucky with that and have had lots of partners who have been working with us to make that happen. We still rank, as you all know, at the bottom of just about everything. The community health rankings for us for the state of Louisiana, we're like the 50, let me see, I'll give you the right number. Orleans Parish ranks 60th out of 64 parishes in the state of Louisiana in terms of the healthiest communities, okay? Where we did shine for us is that we have what is considered, I say this, we're in the top 1/3 in built environment, which is how do we build our neighborhoods, how do we put it together to make those neighborhoods work for the community. And that's really, a lot of hard work from the community. And after Katrina, as neighborhoods were put back together, trying to figure out what's the best thing to put in those neighborhoods and how do we make sure that it's walkable, has bike lanes, parks and those sort of things. We're also the top 1/3 in clinical care, and that's because of all the primary care access that we have. We have a network that is tops in the country in terms of making sure that citizens get primary care, a model actually for the country in terms of that. And we're in the top 1/3 of cities that want to change behavior, right? There's a lot of things going on here that are leading us and people who are saying we don't have to be that way anymore. We don't have to not be healthy. We don't have to not eat healthy food. We like to exercise. Those things that New Orleans was not quite known for before, that's starting to happen. And that's not only with citizens who were indigenous to New Orleans, it's people coming in with new ideas, but there is a palpable change in how people are viewing health and the fact that they're trying to do healthy things. So that gives us, that hope that goal for 2018 of becoming one of the healthiest cities will be there, because we do see it in our communities. We do see it with the people who are here and how they want to see those changes happen. So that's happening for us. Some of the things we don't do so well in, 27% of our citizens are uninsured in Orleans Parish. So that access to the federal Medicaid changes that were coming down is important for us, because that's the things, healthcare is not the only thing that makes the difference, but it is still a big piece of whether or not a person views themselves as healthy. That's a large number. We have what's called more poor mental health days than other cities. I'm not sure what that means for us. I think that, again, in terms of where we are, there's a lot of stressors and those sort of things that are here, but they measure that, and we do fall into the bottom of what that is for the state. We have a murder rate 7 to 10 times the national average for 30 years. And then we have high rates of teen birth and sexually transmitted diseases. 41% of our children live in poverty. So 41% of our children are eligible for the programs that are out there. The goal is to make sure that they have access. And that's where that role that we play in giving access is so important. If the services are available to them and they're not registered, we're out there to find them, to make sure that they do have those services, and making sure that their parents know what those services also contain. It's one thing to say you go to the pediatrician, but under Medicaid, they're also covered for dental services. They're also covered for vision services. Those are the things that are going to affect them when they get to school and whether or not they can perform. So, it's a lot of education for the community on what needs to happen. These are the things that in time are going to change the community in terms of making sure people are accessing all of this, and just changing that, flipping the whole script on how and what's healthy for us. And that's what we focused on and rebranded ourselves to do that. So I think that's about it. It's a lot going on. If y'all have any questions or comments, I gave you our strategic plan because it is aligned to what we are looking at as priorities for the city, so you can see that. All of this information, all of the manuals, all of the publications are on our website, and we welcome you going there and looking at it. And if you have any questions, by all means, give us a call. Thank you.
Thank you.
Situation. Who are the underground people who are helping people who have cancer?
I'm sorry, I couldn't hear you.
I'll give you a mic and remember.
Okay.
Let's stop it. So in the emergency situation, is it the fire department or paramedics who is on the ground helping non-ambulatory people stuck in high dosing? And what is the health department's jurisdiction over those entities?
So the persons who are helping with that are all of those people. It is a plan that we develop with the fire department, with EMS. EMS is primarily responsible for those patients who are ambulance or bedridden. So we divide our citizens up based on the type of ambulatory needs that they have. If a patient or a citizen has medical needs, but they are able to get to the front door of their house, right? And we use ADA compliance measures to figure that out. They can get to the front door of their house, then we send the fire department to go ahead and help and pick them up. And we have transportation services that help us get them to the final destination. If they are bedridden and have been identified, of course, ahead of time, EMS has a staff that will go out ahead of time to assess what the needs are for that client, so that we know we're dealing with someone maybe who's home and they're bedridden, but maybe they're on a ventilator or this or that. And that way they know how to transport them. We then literally sit down and try to map it out. Based on neighborhood, we try to let them know when we're coming. We have an automated system that says we're going to be picking up in the next half hour, so be ready. We do a lot of education on the front end to tell them what they can bring with them and what they can't bring with them. We also do transportation of their pets. Right? If they have a pet, and there is a law now after Katrina about how you handle transport of pets in an emergency. Okay, so our focus are on those people who have pets under medical special needs, and what we do is again identify how big is the pet. Do you have a carrier for the pet? Does the pet have any medical problems? Those kind of things. And then the fire department assists with that. So the fire department takes on a major role in all of this in terms of getting the logistics done of where we are. The health department spends its time identifying who the people are, and then how do we take care of them from there. So it really is it's a dance that we all do to make it work. In Isaac, we weren't evacuating. Right. So, but after the electricity went out, of course, we called all of the people we had on our list, which is about 1,500 names that we've identified, but we know it's much more than that. Then when the electricity went out, we started getting the calls. And the calls were, I'm stuck here, I'm stuck there. In terms of legislative pieces for assisted living facilities, there's not a lot out there. But that is something that we're looking at as to what can we do. What we really did do afterwards, though, is go to every single facility and identify whether or not they had generators in place, what do they have to help, where are these people, and we're going to spend our time now looking at who they have. And something as simple as you have a new person coming into your facility and they're in a wheelchair. Can you try to put them down on the first floor versus putting them on the 8th floor? What can you do to make that work? There's nothing that says you can't. If they have elevators, right, during normal times, it's not a problem. But if the electricity goes out, that's when it becomes that. So some of it is some common sense things that we just want to get them to start thinking about to understand how do we make the problem a lot easier versus as complicated as it was.
Okay. First of all, thank you very much for coming out and spending time with us. Really appreciate it. I'm curious to know, to what extent do you find that other jurisdictions look to Orleans Parish Health Department for guidance on disaster resilience in general? I mean, just thinking especially about, New York and New Jersey and the issues they've faced public health-wise with regards to Sandy. To what extent has your department been working with them and advising them about issues they may face? And then again, more broadly, to what extent do you find that other jurisdictions look to your department for guidance to prepare?
I think that probably prior to Sandy, not much. And I think a lot of that had to do with our health department in general and what we look like, because again, our focus was not public health, right? Now, in terms of emergency preparedness, the city of New Orleans with Homeland Security has been asked many times about, tell me how you do it, what do you do, that sort of thing. But the health department now is coming into its own in terms of this is what we think we need to do for it, and this is what we've done. It has been successful. I think that sort of the pieces with the federal government now in identifying persons that may have issues, we're walking a line here because, of course you have HIPAA issues and no one, you always want to protect, the privacy of the citizens. But in an emergency, how do you serve the citizens best? And I think what we've done is had conversations to say, there's got to be a way to make that work so that citizens are served. And like I said, I think after Sandy, what we started seeing, through emails and everything, the exact same issues, identification of citizens who could not get out of the home or this, and they had medical problems, and how do you do that, and all those things. So really, the issue is universal, so then you start looking to communities that are doing it, and you say, okay, tell me how you did that, because it wasn't quite so successful for us, and we want to make sure we have a better plan the next time. So I think that what comes out of this pilot for us is to probably inform the country on what's the best way to deal with clients with medical special needs. And that's what we're hoping that comes out of this. We are the experts right now in terms of how do you move them, how do you evacuate. Hopefully this will help us to be able to show that this is how it's done, and write about it and put it out there so people can learn from it.
I was curious to know about the FIT NOLA program, and you mentioned that there were 150 partners that came to the table. In 2009, the tax code for community benefit changed for hospitals, so they're required now to be contributing to changes in the community. So I wonder if you had hospitals at the table for FIT NOLA's planning, and if you're seeing a change in their role as a partner since then.
I don't think we've seen a change in their role. Yes, we did have hospitals at the table. The hospitals are trying to figure out now what does all that mean in terms of doing the assessments to understand where and how the community needs were met. We just finished our own community health assessments and created our plan going forward as part of our accreditation process. Hospital was at the table for that, but they're in their own piece now trying to get their plan settled. I do believe that in time, because of the partners that we have, you're going to see where some of those benefits and those fundings that need to be used needs for the community may feed down into FitNOLA. It has not stopped us in any means. We are out there searching for the funding that needs to be there, and more than likely, it's a plan that has many pieces in it. We're looking for people, if they're not going to fund, of course, the whole thing, that would be nice, but if not, pick a piece of it. Can you fund the piece that's dealing with activity? Can you fund the piece that's dealing with fresh food initiatives? Let's talk about how we do that. So we spend our time trying to figure out who's going to pick up those pieces and parts. Because we don't have, that pot of funding, that has not stopped the work of what needs to be done. And actually, they're going to have their next forum for the groups are going to be held, I think, on March 21st, where we're bringing everybody back to say, okay, this is where we are. What is this segment doing? What are you doing? What are you doing to inform the plan and know where we're going forward?
Hi, my name is Veronica Versman. I work with the Louisiana Language Access Coalition.
Mm-hmm.
And I'm really happy to see the strategic plan coming out, and wondering how language access for limited English proficient clients, especially in healthcare, is part of that plan.
Well, good question. One of the pieces, again, through accreditation, but also because we know it's the right thing to do, is that we need to develop through our diversity pieces. We already have partnered with the Language Access Coalition to know what's out there. And Dr. DeSalvo, I think, was part of the initial group that developed that. We're trying to figure out now, excuse me, we want to make sure that if we are doing interpretations and we are we're translating our documents, that we're translating them with someone professional to make sure we do it the right way, and we're not just depending on volunteers to do that, which is good, but there are many different dialects in what we're doing. We understand that that's a big part of what needs to happen for the city of New Orleans, and working within the city on how do we do it from the whole city versus this. One of the things that came out when we met with the coalition was during an emergency, right, you have someone there to interpret for those who are deaf, but then people don't keep the camera on them for people to see it. It sounds, but it's true. It happens. And when the TV goes out, right, and you're dealing with radio or other ways, how can you help to make that happen? So there's a group that we have within the health department working on language access and ensuring the cultural diversity that we're serving everyone that we need to serve. So it's hopefully to be embedded in all of our programs going forward. Okay. That's right.
Oh, hi, sorry. Going back to evacuations and emergency preparedness, I know you spoke a lot about non-ambulatory people who have access to medical equipment that requires electricity. However, I'm curious about what is the city's plan, or if there is a plan for people with cognitive impairments, specifically people with ASD, or who may still live at home or who may live on their own. What's the city's plan to help get them evacuated, get them safely?
Okay, so in part of that assessment for persons, we do a couple of things. One, of course, citizens who identify to us, and in some cases that's not going to be the case. A family member may be the one to identify the person to us, to give us the information. The next level is healthcare providers or case managers that, trying to inform them that there is a city-assisted evacuation plan. We need to know about the person to be able to do that. So if you are caring for someone or doing case management for them, please contact the city so we can know where that person is. Part of the identification under the health department is if the person has cognitive issues or they are on medication for certain disease, we know who they are, and we work with Metropolitan Health to make sure that there's persons when we are evacuating there who can help us to understand what needs to happen for those persons that are coming in and needing assistance. I do think that, again, on the big picture, once we finish the pilot to identify through Medicare who those persons are, if it works, then the next step would be to look at Medicaid. Right, and if we have people who are being serviced through disabilities and that sort of thing, that we have another mechanism to identify where they are. This is going to be a couple of year process for us to get this done, but we all know that We got to figure out how to identify from other sources that are out there versus us waiting for people to call us, because it's not going to work. So until we have those other systems, we have to make sure that the caregivers that are out there, family members, hospitals, anybody who comes across people that they know are going to need assistance, they make sure they call the city's 311 line and get those persons registered. And someone from that point, from the health department, will call them and get the details of it, but they at least let us know where they are, and we will make sure that we get their information.
Thank you very much. Thank you very much.